Hello, everyone. Welcome to the next show. Prescriptions are absolutely everywhere. Mind-blowing, the statistics on the number of prescriptions out there. And I believe that we are soon approaching the point, if not already at the point, where the amount of harm may well outweigh the good. And we are going to talk here very openly, honestly, and transparently as three doctors who practice at the front lines about the medications that we see the most issues with, especially in anybody over the age of 60. And for anybody who enjoys our discussions, please also check in the link down below. We have our own separate, unique channel where we talk about a lot of these issues and healthcare issues affecting you. So the very first medication I want to talk about, it's on the tip of my tongue. You gentlemen know the medicine I'm going to talk about, hydrochlorothiazide, also known as HCTZ, and it is a very common medication prescribed for blood pressure. What are some of the issues we see? I see many, but I'll let you gentlemen go first.
Yeah, in my field in cardiology, I see hydrochlorothiazide all the time. And, it's one of those medications that lots of people are on for blood pressure. And I really feel, and I'm really strong about this in my practice, is tailoring the medications for the patient. And, and one size does not fit all. And in hydrochlorothiazide, especially as people get older, it's just not my favorite for a number of reasons. Because one is, I think we all know, and a lot of patients you all there might appreciate this, is dehydration. And a lot of people don't drink a lot of water during the day because they want, they don't want to get up in the middle of the night to go to the bathroom. And that's because of just changes in our bladder over time. And but dehydration is a huge component which I see from hydrochlorothiazide, because by nature, it's a diuretic. Electrolyte abnormalities. And for me as a cardiologist, that's really, really big, because I do know, and we know that hydrochlorothiazide drops potassium, magnesium, and a lot of times what that can lead to is irregular heartbeats, atrial fibrillation, people who are predisposed to it. And really, that's why I often advise people to take a magnesium supplement as well.
Yeah, absolutely. And I want to also stress, we're going to go over some medications here. Some of them may surprise you. Never, ever stop any medication yourself if you're on any of these. Always speak to your trusted doctor if there's any issues. For some people, these medicines may work, but they should always be weaned down or stopped under medical supervision. That's absolutely paramount, because there may be a good reason you're on that medicine in the first place. So hydrochlorothiazide, I completely second what our resident cardiologist says. It's not a resident, but resident here in this podcast. Absolutely, I tend to see people who are on it for blood pressure, and they will become very dehydrated because it's a diuretic, and they will come into hospital, especially if they've taken it while they're becoming sick, and their potassium will absolutely be down in the floor. It will be like 2.5 or 2.6, very common occurrence. And actually, for our international viewers, in the UK, this medicine equivalent is called bendroflumethiazide or bendrofluazide.
Okay.
Yeah.
Yeah, there's another variant of chlorothalidone, but low potassium, so Ben, you guys probably see this in the form of I see it in the form of arrhythmias and irregular heartbeats, but what do you guys see as an effect of low potassium in your patients?
Yeah, so we'll see that as weakness sometimes.
Yeah. Muscle cramping is a huge thing.
It's a big thing that we start to see. So then we'll check it. We also sometimes see renal failure with this. So we'll see some, and that's your kidneys we're talking about. We'll see some, a little irritation. The kidneys are very fluid dependent. So if you're on something that dehydrates you, it can kind of irritate the kidneys a little bit. So sometimes we'll see that with this medication as well.
You guys see that in your practice as well, just this dehydration component where people, people just in general don't drink fluids during the day, and that is just so, I think that's what I just, really driving home about this medication.
Yeah, absolutely. So if you're on hydrochlorothiazide and this might be a concern for you, please speak to your doctor. If you suffer from low potassium or you get dehydrated, then look into it. I find it surprising, actually. I see a lot of, obviously I work in the hospital, and I'll look back in the records. Lots of patients will be running at a low potassium for some time, and it's obviously is the reason for it. So yeah.
Oh, I see it.
Something else. Yeah.
You're right, Suneel. I see it all the time, and potassium is never repleted. People often overlook it. I think people often underestimate the power of electrolyte abnormalities. And so for a lot of my patients, I always recommend when they're on hydrochlorothiazide to be on a magnesium supplement like magnesium glycinate, which I think is probably the best form of magnesium that's well absorbed. But and listen, it's a good blood pressure medication for younger people. I just particularly as a cardiologist don't love to use it in other age groups.
So magnesium supplement, or even potassium supplement, or even take potassium containing foods. Lots of vegetables and fruits out there, but I would rather you didn't need to do that. That's our good friend, the train again, from our earlier podcast. So that train is cheering us on if you hear that. So Ben, you have something.
The other thing I was going to say is sometimes people will be on other medications that lower sodium and potassium or diuretics at the same time. You'll see that often. And then that will compound the effects of this medication by causing worsening electrolyte deficits or worsening dehydration, kidney failure. So you have to be careful with that too. You have to make sure the medicines you're on aren't interacting.
And this is more probably in your realm too, is that hydrochlorothiazide, poor hydrochlorothiazide, I feel like we're really attacking it now, but it raises uric acid levels too. So people with gout, which, as we know, is so painful, and a lot of you probably may have experienced out there, and that can lead to, exacerbations of gout. And actually, I do believe that hydrochlorothiazide just has a component of raising blood sugar a little bit. It can cause a little bit of hyperglycemia.
I mean, undoubtedly, I speak from the heart. I would never want any relative of mine over the age of 60 on hydrochlorothiazide. I know even told some, just get onto something else. So first medication there that we want to talk about. Let's talk about our next medication. Peter, any cardiac medications that concern you?
Well, there's a whole list. One thing that I do see a lot, and again, I'm seeing patients in a very specific population that have been referred to me because they have really high blood pressure or really resistant high blood pressure where they're on multiple different medications. Often, people are put on beta blockers, and it's a very common medication. Beta blockers were studied a long time ago. They've been used a lot, but I do feel like in order to achieve good blood pressure control on beta blockers like metoprolol, atenolol, you have to be on really, really high doses. And a lot of these patients come in to see me and they're just, they just feel like zombies. Or often, and this is a really important thing, is that a lot of times, especially in our older population, they just think that's because of their age. And in reality, it's actually not. And I think people just assume, well, you're at this age, you should feel this way, but you knock the medication, take it at night. But it's, fatigue side effects, is a huge component of that medication, which I just don't love.
Yeah, no, I totally agree. Beta blockers can be very hard to stop, though. I mean, certainly when a cardiologist prescribes them and you're trying to control, atrial fibrillation or something like that, they can be hard to stop. But man, they have significant side effects. I mean, I have a lot of patients that come in are very fatigued since starting them, and we'll try alternatives, but that's a huge side effect we see.
Yeah.
Especially at high doses. I've seen that with a high dose. I must admit, I've had more success with very low doses. I think obviously beta blockers reduce cardiac contractility. They have other effects as well. They bring the pulse rate down. They can be good with atrial fibrillation, but I've actually said before, I can't think of any category of drug which is actually used for more indications. I mean, it has a use for migraines, has a use for people with tremors, but I've seen it be really good, but at low doses. But yeah, higher doses, definitely. Fatigue, other issues.
Yeah. Well, we do know, and this is a lot of medications too, but especially with beta blockers, you get the most effect at lower doses, but as you keep doubling the dose, you're really just exponentially increasing those side effects. So I mean, you're right. So there is a lot of times that it's really useful in things like controlling heart rates, people who have palpitations or the awareness of your heart beating in your chest. It has a good effect on that, but I just feel that the daily use of that medication, unless there's a really strong indication, like some people would benefit from it, but to use it purely just for blood pressure control, I'm just not a big fan.
Interesting. Okay. All right. So yeah, there we go. Hydrochlorothiazide, beta blockers. I want to talk about medication next that I would probably put second to hydrochlorothiazide on my list of disliking, especially in the over-60s, and that's gabapentin, Neurontin, which is commonly prescribed for nerve-related pain. But my issue is, I mean, since I've been in practice in the United States, seeing whopping doses, like 900 milligrams plus 3 times a day, and I've just seen people zombified, come in, they're knocked out. And often when people come into the hospital, they're sick with something else and will cut back on all of their medicines. and they'll wake up. And I've had relatives say to me, I've never seen my loved one so awake before. And this is someone who's over the age of 60. And I'll say, well, guess what? I stopped their really high dose of gabapentin, which was knocking them out. So not saying it like with the other meds that it doesn't have any effect, but I have seen so many people over the age of 60 knocked out with this medicine. And of course, if you're knocked out, you're not experiencing the nerve pain.
Yeah, I think the problem with gabapentin is you're trying to treat a condition that's very hard to treat. It's usually you're trying to treat nerve pain when you're giving gabapentin. The problem is a lot of the time it's nerve pain coming from the back, like sciatica, stuff like that. And it's incredibly hard to treat that pain. So there are really limited options. And a lot of time doctors go straight to gabapentin. Gabapentin it's just a poor drug overall. It just usually does a pretty poor job of treating the pain. Anyone that's on it will usually say that. Every now and then there's somebody that says it does a great job. But that's pretty rare. Most people tell me it just doesn't work very well because the pain is just hard to get to. What happens is they need higher and higher doses. So they end up getting on doses where the side effects far outweigh any benefit they're going to get. And what you start seeing is, yes, they're zombified, they're exhausted, their quality of life goes down. But what they're really trying to do is take care of this pain and back pain, sciatic pain. That's a tough pain to treat. So
It is. And unfortunately, that affects a lot of people. I always feel like I should be a cardiologist / orthopedic, not because most people have complaints of back pain, and knee pains as well. But even as a cardiologist, I can pick up on gabapentin now as a adverse, reaction or side effect, because I have a lot of patients that come in on really high doses and they're feeling awful. The problem is that this polypharmacy, that people don't, we're adding on medications.
Yeah, which we've
not taking them off. So
Okay, everyone, I'm going to interrupt this fantastic discussion for a moment to tell you about our amazing expanding natural supplement store, my uniquely formulated natural supplements. We have immune support, bone support, memory support, heart support, and sleep support. Links down below. High quality supplements. We're very proud to be made in the USA and we work with a veteran-owned company. I'm also very excited. Keep an eye out for this. Our upcoming organic chai tea mix, based on the tea that I've been consuming for many years, a health and well-being tea. ohighwellness.com if you're in the USA, North America. ohighwellness.co if you're in the UK, Europe. Check the links down below. Okay, back to the discussion. Gentlemen, what other medications?
Well,
here.
You go ahead.
Well, I mean, I think the one medication that's not really directly a cardiology medication, there are some indications for it, is the like the proton pump inhibitors, the acid reducing medications. They do have their place, but the problem with that is they're the correct use. I think it's more the correct use of it. And I can't tell you how many times that I have patients come in and I ask them why are they taking a medication like Pepcid or omeprazole. And a lot of times, it's a reflex when they're in the hospital, they're discharged on it and they've been on it for years and they don't even know if they have heartburn or not. And I always just say, we really need to figure out like why you're taking this, because we know that, these medications, as simple as they may seem, cause like, deficiencies or problems with gut health, osteoporosis in people, in my realm, significant drops in magnesium. I mean, I've seen whoppingly low, magnesium levels in people, on these medications that are just simply, even over the counter now. So,
Yeah, you're absolutely right. And a lot of these meds are not necessarily made to be lifelong medications. I mean, if you're having significant reflux, there are a lot of things that should be done besides just putting you on a PPI or an acid for eternity. I mean, you really need to figure out why that's so bad. You need to adjust the diet. Usually, sometimes you need a procedure like an endoscopy to look and see what's going on. Why is it so bad? And just putting someone on an antacid like that, a PPI, and leaving it on forever, is really not good. Your primary care should be readdressing that with you pretty regularly and making sure that you should still be on that or not. So I agree with you.
Yeah, I find that medication almost on every patient's list that comes out of the hospital.
It's a default, yeah.
A complete default.
I mean, need it.
We know when people are in the hospital, they're at increased risk of under stress of gastric ulceration. And so sometimes that started to help protect their stomach. but it's just people are discharged on it. And that's very classic in our healthcare system is starting medications and adding medications to offset side effects, but no one's ever stopping it. No one's ever asking you. I mean, I guess when's the last time someone has asked you, like, has anyone told you to, how long you should be on this medication for? People just assume that some other person started it.
I think this is so important. In fact, I had this conversation today in the hospital with someone who was kind of overwhelmed after a heart attack, and we'd started all these new medications. And I said, look, this is not necessarily forever. You go, you get better. And in this case, lifestyle was an issue. I said, make some changes. Absolutely gave some advice. And in 2 months, you might not be on these medicines. And with reflux, people changing their diet most of the time helps. So great point. I want to talk about another blood pressure medicine that I see issues with frequently. It's called amlodipine, and it's a calcium channel blocker, also known as Norvasc in the United States. Do you see any repeated issues with this?
Well, I mean, amlodipine, I will say I agree and disagree a little bit. I think amlodipine actually is actually a good blood pressure medication, but the side effect of amlodipine across the board is ankle swelling. Yeah. And I can't tell you that, but I think it comes down to the point where people panic or get really concerned that they might be in congestive heart failure because you go online and you realize they have ankle swelling, and it's just really someone starting medication and not telling you the side effect. I think that for me, I do think it's overall good blood pressure medication when you educate the patient about it. You tell them, like, listen, you may get puffiness in your ankles, you may get a lot of ankle swelling, and a lot of times it could be a side effect. But your thoughts?
I totally agree with you. I agree. I think it is a good medication for blood pressure, but it comes with 2 side effects I see pretty regularly. One is definitely the ankle swelling. Again, if you get that, it's usually not going to go away. Even if you lower the dose, it might go away to a degree, but it's still going to be there. So once that side effect happens, and it's a pretty big deal. I mean, people can't put their shoes on. They have trouble walking. It's a pretty big deal when you get that side effect. So, and the biggest problem is you'll start going to different docs and they'll start doing a whole workup to figure out why in the world you have swelling in your ankles, not realizing it was the medication. So that can be a huge issue. The second thing I see is something called orthostatic hypotension that we actually see a fair amount of, which is you'll stand up quickly and be incredibly dizzy or pass out. We do see that with this medication and other types of blood pressure medication. So if you're having that issue where you stand up and you're getting dizzy, ask your doctor about it. Say, could this medication maybe be doing that? Because we see that a fair amount. So those are 2 things I'd say about that. You got a good medication, but...
Yeah. Amlodipine, I do believe as a calcium channel blocker, that class of medication can also cause heartburn or worsen heartburn in some people. And I don't know if you guys see that a lot. I mean, I've come across a couple of times. Also, constipation can be a factor in that, medication. But
yeah, absolutely. I find it like quite a powerful medication. Typically, we don't use it first or even second line. There are certain demographics, including African Americans, where there is more evidence for its effectiveness. But yeah, leg swelling are fairly common. So let's move on to our next category, which we're actually going to dedicate a whole podcast to really soon, on statins. But we all have our own thoughts on statins being prescribed and issues with them. I have seen often older people be put on these massive doses of statins with very questionable evidence, because these groups often aren't studied and have side effects including weakness, muscle aches, or their liver function tests go up.
Yeah, I mean, for me, I mean, that's, this is my everyday practice is statin medications, and really a lot of those older populations were excluded from these trials where statins were effective. And I think just overall this obsession with, cholesterol has gotten a little bit out of control, especially, there are certain hard points that people, really should be on a statin medication if they have a heart attack. But, if you're older and your cholesterol is elevated, is it really the best thing to be on a statin medication where you risk things like myalgias or muscle aches or in muscle inflammation? I don't think so. I don't really believe as a cardiologist using statins in older people.
Yeah, it's very questionable when you actually look at the data and get over this obsession that a medical establishment and profession has with fixing a number and getting very excited. Yeah. We all had thoughts on that, which we'll talk about more. Do you see issues with statins in primary care?
Absolutely. Yeah, I mean, I can understand the excitement because it really does. It fixes the numbers right away. You'll see it. Like you'll check the numbers as you watch it later and they're perfect. The problem is the side effect profile is pretty impressive. I mean, it's not a small amount of people that develop the side effects. I mean, I see many patients that we try to say that have been on these or someone tries to start them and they do develop the side effects. And the myalgias are very real. It can be an overall kind of just not feeling well, or it can be really kind of intense pain in your muscles and your joints. And it's the point that it can't continue. You have to stop the medication. We'll experiment, you'll try different ones, but typically if you're having pains with one of them, it's pretty rare you're able to get to another one that you have absolutely no side effects from. Now that's temporary. You can go off the medication and those pains go away, but the liver function can be quite dangerous. So if your liver function tests are going up from a statin, that's a pretty big deal. I mean, you need to get off that right away. That can really hurt you.
Yeah, and then that's important in monitoring. But I think there's overall an expectation. It's sort of like hot potato. Everyone passes it. Like someone's cholesterol is elevated, and it's kind of passed from doctor, and you kind of you feel like maybe one other doctor expects you to I guess maybe as a specialist I feel there's a certain expectation that if your cholesterol is high that the cardiologist is going to put you on a cholesterol medication.
Mm-hmm.
I actually really don't like that feeling, and I don't do that. I think it really drives to tailoring it to if you truly need a statin medication, if you've had like a heart attack or you have coronary artery disease. I mean, there are really clear points where people do benefit from it. But when you're older, if you're in your 80s and someone even late 70s and your cholesterol is borderline, and someone is trying to put you on a statin without actually talking to you about what you can do to maybe avoid getting on it.
Absolutely.
Yeah. Or such as a great point.
Like lifestyle changes, dietary, exercise. I mean,
yeah, because you're a good cardiologist, if you feel that way. Yeah, it's not all about the numbers. So, okay. Well, we hope that discussion was helpful. We will end with a short statement from all of us. Now, I actually think we could go on with medications to be careful of, but what we really wanted to cover was our own experience as doctors with the medicines that we see the most issues with, particularly in the over-60s, who are the majority of our patients. My two are hydrochlorothiazide and gabapentin. And I would just urge everybody out there to understand that every prescription that you or a loved one, it's not only about you, you probably have a loved one who's getting escalating lists of medications. Just remember that every medication has side effects and there are enormous conflicts of interest. And this is a whole industry, and it profits especially from older people going on these medicines, which are frequently thousands of dollars a month, and they come with side effects. So just be careful, make sure that every medicine is right for you, and absolutely never be afraid to get a second opinion, because there's lots of alternatives usually.
Yeah, absolutely. I think always know every single medication you're on, always know what's being prescribed to you, and you have the right to have that explained to you. Do I need to be on this? What does it interact with? What are the side effects? You deserve the answers to those. You can do your own homework, but you can also demand from the doctors you're seeing that they tell you. And, I think educated patients are the ones that do the best. So the more you can educate yourself, the more that you demand you're educated, I think the odds are you'll do much, much better.
You really do have to be your own advocate in the healthcare world now. And I always strive to my patients really is to have, when you're seeing a physician, or to really have them analyze your medications. And lots of patients will ask me a lot of times, like, can I stop this medication? And I'll be frank with them. If I think they should be on it, I'll tell them no. But I do tell them, when I see you back, if I see you back in 6 months, you should always ask me that question again. All right. Well, it's not one medication fits all. You should really ask your doctor, is this medication appropriate for you? Because your body changes over time. Volume of distribution of medication changes, side effects increase.
Absolutely. Very well said. Okay, everyone. Thank you very much for watching. Once again, do check in the links down below for our separate channel where we have lots of interesting discussions, and we are soon to be taking requests as well on topics. Be healthy, and we will speak to you again very soon.